One, start, sir.
Good evening, everybody. It's a pleasure for me to be giving this talk for the Heroes and Train, which we do every year. And this time, we are doing in a video format. I thought I should share my experiences of treating vertigo because I've always found that treating vertigo has always been made out to be very complex. So I would like to share 2 cents of my wisdom in treating a case of vertigo. When a patient with vertigo walks into my room, I give maximum importance to history. As most of us you would agree that most of the times, the treatment of any illness, history is 70% and more so in vertigo. I first allow the patient to speak for a minute or two for him to describe the vertigo. Because many times what the patient thinks or has been treated as vertigo, I have found in the history that there's no vertigo at all. So usually I ask them whether they have a sense of rotation or is it unsteadiness or heaviness of the head. And in many of the cases, I have found that it's not been a true vertigo at all. So first thing is I ask them when was the first episode? Did it come early in the morning? I ask them the duration of vertigo. I also ask them whether it is associated with nausea or vomiting. And again, whether the patient is feeling that the body is getting dragged to one side, any history of trauma, and also the history of any drugs being taken recently. I also ask them about associated hearing loss or tinnitus or blurred vision. Once I make this, the next thing I do is I send them for what I have coined as the DREM test. DREM is the short form of, the Dix-Hallpike test, the roll test, extended head hanging test, and finally the Epley's maneuver, which becomes DREM. As you're aware, Dix-Hallpike is for the posterior canal, then roll test is for the horizontal canal, extended head hanging test is for the superior canal, and the maneuver, of course, we do depending on whatever is the vertigo. In select cases, I do a video nystagmogram. We also check the BP to rule out postural hypotension. And then we also look at the heart rate. Though a more accurate variety of ruling out cardiac vertigo due to arrhythmias or bradycardias would be to do a Holter valve monitoring. And of course, we try to do a complete vestibular examination. My first concept in any case of vertigo is, I say among the 100 cases of vertigo, 90 of them belong to the ear, or what is called as otogenic vertigo. Number two, out of this, 90% of the cases of vertigo, 90% are coming from the ear, and 90% of the things coming from the ear, 90% are benign paroxysmal positional vertigos, and out of them, 90% are posterior canal vertigos. So if you go by the rule of 90, 90, 90, 60 to 70% of all vertigos are benign paroxysmal positional vertigos, right? So I tell people that try to treat a benign positional vertigo properly. You'll be successfully treating nearly 70 to 75% of all vertigos. The second category of vertigos are the non-otogenic vertigos, the remaining 10%, out of which the biggest component is the migraneous vertigo, complaining of 4% or roughly so. Another 3% or 4% is occupied by psychogenic vertigos or phobic vertigos or anxiety-related vertigos. The remaining 2% or 3%, you have low, that is either low blood pressure, low hemoglobin, low heart rate, low sugar, or low perfusion where, patients have had cardiac diseases, angiomas, the blocks in the blood vessels and things like that. And finally, low vitamin D and low vitamin B12. Another very small percentage, maybe 0.5, are the central vertigos. like any central diseases, which of course fall into the ambit of neurology, and paraneoplastic syndromes very rare. So many times we have a funny situation where the patient, every time they come to our OPD and every time we do the DREM, everything looks normal. And poor patient, if they're from outstation, many times they get an episode of vertigo at home or at their workplace when they can't come to us. So we have devised a new thing where we tell the patient, don't, you go ahead and record, keep the mobile phone right opposite to you. Either attendant can do it or somebody else can do it, or the patient himself can take a selfie when they're actually going through the vertigo, where they keep their eyes open and record the nystagmus. And that is a very invaluable input when they come to us and show 2 or 3 such videos. And we can look at the nystagmus and make our diagnostics. And the most important thing what I have seen is more than a VNG, more than a stabilometry, more than an ENG, a good DREM test done recording the nystagmus tells us most of the diagnosis. The most important thing in this whole thing is that you should always take the history of drugs. Many times you have seen patients who have been using betahistine or sinerizine or meclizine for many years. We have withdrawn the drug. The first sitting on DREM, we didn't notice the nystagmus. The second sitting, we didn't notice the nystagmus. After 6 months, we suddenly realized it was a case of simple posterior canal BPPV or a lateral canal BPPV, which was simply converted into a chronic vertigo because the doctors of various specialties kept on giving vestibular sedatives, which never made the problem completely all right. In fact, now I say there is nothing called chronic vertigo. A chronic vertigo is either a phobic psychogenic vertigo or a vertigo which is rendered chronic by the incompetent physician treating it. So I say chronic vertigo is idiopathic. It is an idiot doctor and pathetic patient. Finally, to talk about Meniere's disease. Meniere's disease is often overdiagnosed by people across all specialty because if the audiogram shows a hearing loss or a sloping loss or patient complains of tinnitus, which is unconnected to the typical history of episodic vertigo, we make a diagnosis of Meniere's. Many times these are migraneous vertigos or phobic vertigos or BPPVs with coinciding SN loss and tinnitus shown on audiogram. We also believe in doing an MRI in most of these patients so that we rule out any associated central cause. There is not a rule that a patient should only have a peripheral vertigo or a central vertigo. Sometimes you can have a mixed lesion where MRI and a neurological examination becomes very, very important. Even in Meniere's disease, I have found that more than giving vestibular sedatives, once it is confirmed by the history that it's endolymphatic hydrops, or you can also do an intratympanic gadolinium-based MRI scan during the acute phase to confirm or rule out endolymphatic hydrops. I have seen diuretics work wonders. I use a combination of furosemide with spironolactone and it has given me excellent results. Only problem is after using it for 1 month continuously, better do one serum electrolyte analysis, and if the electrolytes are normal, you can give it as long as you want. There's absolutely no problem. And the intratympanic dexamethasone, if it is given during acute phase of Meniere's, single shot or 2 shots, can also prevent the further SN loss and tinnitus. And because it's intratympanic dexamethasone, there is no harm in giving it. Me giving intratympanic gentamicin in Meniere's has become extremely rare. Maybe I now give it only in patients who have drop attacks in Meniere's. In that, I dilute 1 cc of gentamicin with 5 ml saline, and then you should be giving it intratympanic and make the patient lie down for 20 minutes. Now I've restricted this to only severe intractable menias not responding to diuretics and patients who get drop attacks specifically. Otherwise, I don't use gentamicin in menias anymore. Surgical treatment of menias is also now obsolete. Finally, in benign paroxysmal positional vertigo, we don't believe in rehabilitation exercises after we do the maneuver and correct. We give them the restrictions and we don't even give drugs other than ondansetron. We don't use vestibular sedatives at all. And only in vestibular neuronitis, I use vestibular sedatives for 2 to 3 months. In that also, I prefer beta-histine over cinarizine because cinarizine has its long-term side effects of Parkinsonism. So I'm extremely careful with using that. And finally, in migraneous vertigo, which is more like a chameleon, the diagnosis is more by omission rather than commission. Then you must always treat it as a migraine, taking the help of the neurologist. And again, in the MRI, if you see small visual ischemic changes, they also go more in favor of migraine. Finally, I still reiterate, treating vertigo is very simple. Please remember, 90% are otogenic, out of which 90% are BPPV, out of which 90% is posterior canal BPPV. Even if you people can withdraw all the drugs and diagnose the posterior canal BPPVs properly, I think you will be successfully treating 60 to 70% of all vertigos. Think of migraine, think of phobic vertigo, think of all the low things I mentioned before. And finally, a caution about cardiac vertigo and then central vertigo. I think you should be able to treat 98 to 99% of vertigos without getting into complex nystagmus and other things. Thank you very much.